Mix-App sessions are always filled with plenty of excellent information, and we often run short on time, so I'd love to go ahead and get started. I'd like to introduce Dr. Alex Collis and Dr. Michelle Sabo, who are going to be running our Mix-App session today, our Mix-App ID session. Feel free to take it away.
All right, thanks for the introduction. So I'm a hospitalist at UWMC, and we'll talk about, we'll do some Mix-App review today for infectious disease. So I'll just go ahead and, I guess, does Dr. Sabo want to introduce herself?
Sure. I'm Michelle Sabo. I'm an acting instructor in infectious disease. And I guess my only other bit of introduction is all my pets are home with me. So if somebody jumps in the picture, that's who they are. But yes, any questions you have, please feel free to ask away. My specialties are immune deficiency and HIV medicine within infectious disease. So, and especially anything in that area, please ask away.
All right, great. We'll get started. And I also have pets that may start screaming in the background, so just ignore that. That happens. All right, let's get started. So first, just some ground rules. We can go ahead and mute your microphones. We'll have you do the raise your hand option if you have questions, or you can propose them in the chat. And then we'll try and come to them at the very end of every section. And then feel free to use your camera or not, whatever is more comfortable. All right, so we have our first question. So a 40-year-old woman is admitted to the hospital for 1 month history of diffuse abdominal pain, fever, sweats, fatigue, and weight loss. She reports no swelling or other focal symptoms. Medical history is significant for AIDS, for which she has begun antiretroviral therapy and opportunistic infection prophylaxis 2 months ago. At that time, her CD4 count was 23 and HIV viral load was 320,875. Medications are abacavir, lamivudine, ritonavir, darunavir, azithromycin, and Bactrim. On physical exam, her temperature is 37.9, blood pressure 122/76, pulse rate 88 per minute, respiratory rate 14 per minute, and BMI was 22. The oropharynx is clear. Cervical, axillary, and inguinal 1 centimeter lymph nodes are palpable bilaterally. Her lungs are clear. Heart exam is normal. The liver edge extends 2 centimeters below the right costal margin, and the spleen tip is palpable. No rashes noted, and the neurologic exam is normal. Her serum, liver enzymes, bilirubin, and kidney function are normal, and chest radiograph is normal. Abdominal CT shows retroperitoneal lymphadenopathy, diffuse hepatic and splenic enlargement without focal lesions, and normal stomach, small and large bowel, and kidneys. Her labs show a CD4 count of 56, HIV viral load of about 5,000. Her hemoglobin 9.2, leukocyte is 3.6, and ALK Phos 349. So which of the following is the most likely diagnosis? A, cytomegalovirus, B, disseminated candidemia, C, disseminated MAC, or D, medication toxicity.
Give another 10 seconds or so. We're just over 50% of people voting.
All right, so it looks like the majority of people said cytomegalovirus. So let's look. The actual answer is actually MAC. So we'll talk about why that is. So this patient in this question has immune reconstitution inflammatory syndrome, or IRIS. So basically what that is, we have two types. We have unmasking IRIS, where we didn't know the patient had an infection. We start ART, and then the infection's unmasked by the inflammatory response. And then we have paradoxical IRIS, where the patient has a known infection, we start ART, and it becomes worse. The likelihood of developing IRIS correlates with the extent of CD4 suppression before we start ART, and then the degree of reconstitution when we actually go ahead and start antiretroviral therapy. So this is going to be more common in patients that initially have a low CD4, in part because they're more likely to have these infections when we actually start therapy. And it kind of coincides with the timeline of how ART works. So we start ART, and in the first 1 to 2 weeks, we actually have about a 90% reduction in viral load. And then that continues to reduce further over the next 8 to 12 weeks. And then over the same period of time, while the viral load's decreasing, we have immune cells reconstituting. So you're going to have an increase in the immune cells over the same period of time. Typically, you're going to get IRIS symptoms in the first 30 to 100 days post-initiation of ART, and typical organisms we see are MAC, TB, CMV, which you guys chose as the answer, Cryptococcus, PCP, HSV, hepatitis B, and then HHV8. So we're kind of between those two answers still, that the one that was correct and the one that you guys chose. And so I'm actually this is a great schematic of how an infection affects a normal host and how an infection infects a patient with HIV, and then what happens when we give them ART. And I'm actually going to turn this over to Dr. I'm sorry, I'm saying your name wrong again, Sabo?
Sabo's right, yeah.
Sabo, okay, I'm going to turn this over to you to kind of talk through a little bit more.
Sounds good, and this is Marlon here, guys. So first of all, because I can't remember the order of your slides, do you want me to back up and talk about why this is or is not CMV, or is that coming next?
That's going to come next.
Okay, because I've got so much for this. I told you guys I do HIV, so this is like a great topic. So when you're normal host, what happens is, I guess I can't point, but if you have a organism that infects, in this case, it's going to be your MAC. And this slide pretty specifically actually shows kind of what a MAC infection would typically look like. You're going to get activation of your antigen presenting cells, and then those cells will secrete numerous cytokines, IL-6, TNF-alpha, others that are going to activate your CD4 cells. Those CD4 cells release interferon gamma, and that allows the macrophage to kill the bacteria. Remember, you need that T cell help to actually get killing. And what happens in a person who has no T cells is you end up getting a lot of infection in your macrophages. They accumulate with all kinds of MAC. And then when the T cells finally reconstitute and are able to recognize that infection, there's excessive inflammation, there's excessive activation of these macrophages, because remember, they've all clumped up, they're all infected, and now all of a sudden they're getting the interferon gamma from the T cells they need to kill and to activate them, and there's this huge burst of cytokines that's released. And so you can imagine, we've talked a lot about this with COVID. I think this has become a pretty commonly talked about topic, but you kind of get like a cytokine storm or this massive cytokine release causing symptoms. And that's what you see. And then of course, you see it in the area where there's the most infection. And so in the case of MAC, for whatever reason, it really likes the gut in these people, less the lungs and more the gut.
Great.
That wasn't too long-winded. We're really, really in my area of love here, so.
Great. Yeah, that's really helpful. Thank you for walking through that. So let me move on. So the diagnostic criteria are kind of going to be what we talked about. So it's going to be worsening of either recognized or unrecognized infection as we're having improvement in immunologic function. You're going to have a low CD4 count before treatment to classify as IRIS, except for TB. This can actually occur with CD4 counts initially greater than 200. You're going to have positive virologic and immunologic response to ART, and then presence of inflammatory manifestations consistent with IRIS and some of the symptoms that Dr. Sabo talked about. And then again, it's going to have to be in that time period, probably somewhere between 30 and 100 days after you've actually started ART. And then lastly, you have to rule out other etiologies such as undertreatment of the original infection, antimicrobial resistance of the infection itself. some manifestations, and I'll kind of let you weigh in on this a little bit too, Dr. Sabo, but you know, fever, painful lymphadenitis, and this is for MAC specifically, hepatosplenomegaly, anemia, leukopenia, elevated ALK phos, and usually you're going to have an initial CD4 less than 50 because that's when you would develop the infection in the first place. And then standard treatment would be clarithromycin, ethambutol, and then actually continuing antiretroviral therapy. I'll see if you have anything else to add to that.
I would say that not really. I'd say my main additions would be that they tend to have, you learn about classically in your classes that they have diarrhea and stomach upset, and we do see that a lot. The low-grade fevers, which will kind of make people think TB with night sweats, weight loss, and then the elevated alkaline phosphatase is a huge, huge clue. I had been told that my anecdotes help people remember, so I'm going to tell this one. I had a very lovely patient who some of you may have cared for last year, who was diagnosed in late 2019 with AIDS and a CD4 count of 4. She reconstituted very, very slowly, so she actually ended up having MAC iris present more like 6 months after we started ART, which is a bit odd. And we proved it was MAC iris because after we treated her MAC, we couldn't grow anything and she still had symptoms. But the initial feature that clued me to MAC was she had an elevated alkaline phosphatase, even as everything else started to normalize with ART. And we worked it up, could never find anything. And then finally, 6 months later, she clearly had rip-roaring iris. Couple other points. Clarithromycin and ethambutol are first line. Clarithromycin is listed in the guidelines because it's the one that we have the most data for, but realistically, people feel really, really nauseous. And so high doses of thromycin is also clinically acceptable and probably more often what you'll see.
All right, great, thanks. So we'll kind of come back now to why it wasn't the other options. And so from what I saw, mostly CMV presents as uveitis or GI symptoms, but it sounds like you have some points to add too.
Yeah, it's mostly uveitis. And I would say what would key you into this not being CMV, I know why you guys thought of CMV, because you all have been on U wards and have taken care of our SOT patients who do get disseminated CMV, which presents with, it's very difficult to diagnose. You have to have an elevated CMV and fevers and rule out CMV in other areas. We don't see it as much in our HIV patients. It's just not as common. And the bulky lymphadenopathy and the GI symptoms really make me think MAC. Especially on your MICSAP, they're not going to give you that weird patient that's presenting with GI or disseminated CMV.
Great. And then we don't think this is a disseminated candidal infection. That's actually pretty rare in HIV. It's most likely going to be your neutropenic patients. And then lastly, medication toxicity. What they were kind of grabbing at was abacavir hypersensitivity, which is actually very rare. If you were to see it, you'd see fever, rash, GI symptoms, hepatitis, malaise, but again, not that bulky lymphadenopathy, which is really going to point you towards MAC. So that's the points that I have for this question. I'll open this up to questions from the group now.
And one other point I want to make, this was an old MICSAP question. Your boards will probably be up to date because they're going to go off of the guidelines. MICSAP is not, but first line therapy for this patient would have been abacavir, lamivudine, and dolutegravir. So it still would have been the same question, STEM, but you're going to have an integrase inhibitor. And then we no longer give azithromycin prophylaxis. So we all learned in medical school, right? CD4 less than 50, you give azithromycin once weekly. But as we have better ART, patients who are started on antiretroviral therapy and have rapid viral suppression no longer need azithromycin prophylaxis because we were finding we were giving patients lots of symptoms, lots of nausea with the high dose azithro, and not preventing cases of MAC. It's different if you have someone who's out there not taking their medicines for whatever reason, because then their T cells are probably dysfunctional and then they might benefit from the azithro. But if they're not taking their medicines, they're probably not going to take azithromycin once a week. So I think you can safely say we're not giving azithromycin prophylaxis in most cases.
For some reason, I can't see the chat feature, so if someone could help me out if there's any questions.
Oh yeah, and then someone said, Ryan said, wondering about this patient being on azithromycin for prophylaxis and still developed MAC iris. And I wonder about dose being different for prophylaxis versus treatment, but would you say she failed prophylaxis? So I have seen this. It's not perfect, and I think what it is if the patient is already infected and you're unmasking, there's just so much organism there that you can't suppress, even with your azithromycin. And you're right, the doses are different. Prophylactic dosing is 1 gram of azithromycin once a week, which, like I said, nobody likes. They're miserable. They get a metallic taste in their mouth. They're nauseous. And treatment doses are 500 once daily. And we don't have to go into pharmacokinetics, but just think about, you're really keeping with a daily dose, a steady level of azithromycin over the MIC all the time. And with this once weekly dose, you're kind of getting a peak. But I think this probably had a foothold well before she started getting prophylaxis. And once her T cells came back, even if the organism wasn't replicating, there was so much in the macrophages that her T cells responded, and her immune system really made her symptomatic.
Okay. Are there any other questions from the group?
I don't see any, but I'm not the most technologically inclined.
Okay. All right. So I guess we'll move on to the next question.
Oh, and somebody asked, if someone has a negative MAC blood culture prior to initiation of treatment, can you feel confident that this person did not have MAC? I would say no. It would make me more nervous. And actually, in these cases, because you have an HIV patient, Occam's razor doesn't apply. So for instance, the patient I was mentioning who had MAC iris, we were actually looking for a lymph node to biopsy to make sure they also did not have some sort of lymphoma. So I would say you can't. I would probably treat for both and continue pursuing workup at that point. I was pretty aggressive, and I have been pretty aggressive just because these folks can fool you. Oh, and what are other typical infections we see with iris? The top ones that I think of off the top of my head, TB. TB is no fun. Cryptococcal meningitis. They can actually get herpes labialis, so they'll get a really terrible outbreak of oral herpes or genital herpes when their immune system reconstitutes, because the immune system is now reacting to the virus that's out in the skin. CMV. I have seen people present with PJP. I've not seen PJP iris. Those are the big ones I think of.
All right, any other questions? All right, I'll go ahead and move on to the next question. So question 2, a 74-year-old woman is evaluated for positive syphilis serologic results. She's being evaluated for progressive difficulty with memory. She reports no known history of syphilis, but lists several risk factors for possible infection in the past. Medical history is significant for hypertension and type 2 diabetes mellitus. Medications are enalapril, amlodipine, and metformin. On physical exam, vital signs are normal. The general physical examination is normal, and her neurologic examination is unremarkable. Cognitive testing is notable for a score of 19 out of 30 on the Mini-Mental State Exam. Findings on serum RPR testing are positive with a titer of 1 to 4. Results of a confirmatory fluorescent treponemal antibody absorption testing are positive. So which of the following is the most appropriate next step in management? A, cerebral spinal fluid analysis, B, IM penicillin, C, IV penicillin, and then D, serum VDRL test. See. All right, looks like the majority of people said CSF analysis, and you guys are correct. Good. All right. All right, so we're going to talk about a couple parts of this. First, we're going to talk about syphilis testing and why this question led us to believe that the patient did have syphilis, and then we're going to talk a little bit about why we did the CSF exam. So first, just talking about syphilis testing. So there's two ways that we can test. One is a treponemal test. So this is actually going to detect antibodies against specific treponemal antigens. This is going to be much more specific than non-treponemal tests. The only downside is that once it's positive, it's always going to be positive regardless of if you've undergone treatment. And then there's going to be non-treponemal tests, and these are testing against looking at reactivity of serum from infected patients to cardiolipin, cholesterol, lecithin antigen. So these are going to give you a reflection of disease activity. So if they're higher, it means you have greater disease activity, and if it's decreasing, that means that treatment has been effective. The downside is that they're going to be much less specific. If we have our non-treponemal test, that's going to be RPR, like our patient initially had, or VDRL, and then treponemal, which is actually looking at the antibodies. So again, non-treponemal gives us an idea of how active disease is. Treponemal, good for screening, very specific. And then I'm going to let Dr. Sabo walk through this a little bit too. So this is a sequence of how we can test for syphilis.
Sure. So Dr. Collis is making some really good points here. I think the place I'm going to start is MixApp is asking you to think about this in the reverse of how we test at the UW. And I bring this up because this is always a source of confusion and one of the teaching topics I use a lot when I attend, because the UW does it slightly differently than other places. And so what I want to do with Dr. Collis' slides in this is try to give you guys the tools to be able to interpret the tests no matter how they're thrown at you. So what we do at UW is a bit of a different screening approach that's in the question. At UW, that's right, you can't see my arrow. At UW, we do the treponemal test first. So yes, exactly. So the treponemal test, if it's negative, there could be a false negative. I'm not going to go down that road too quickly, but if it's negative, we think no disease. They've never had syphilis. This is not positive, you're done. If it's positive, then we want to look at a quantitative test, one of those tests that goes up or down with disease activity. If that test is positive, the RPR, then you can say, okay, they have new or old disease, and what you do is you compare it to other RPRs. So the example I give is if a patient of mine comes in and they've had a positive test, and I can look back and they have an RPR of 1 to 4, 1 to 4, 1 to 4 for many years, and then all of a sudden it's 1:256, I know they've gotten reinfected. The tricky part becomes if it's negative, then you do another treponemal test to confirm. And you can have, if that second test is positive, then you think about them having actual disease and treating them, even if their RPR is low. You can see that in early infection. You can see it in kind of old, burned out disease. You can see it in someone who had disease a long time ago and was treated. And then if it's negative, what's most often I find is that it ends up meaning you had a false positive treponemal test. And that comes up every once in a while. I get a call about that. So what the MixApp question asks, they reverse it a little bit. They do the RPR first, so the non-treponemal test. And that can also have false positives, so then they confirm it with the treponemal test, the IgG. And so you should be able to think about, no matter what, there's one test first that could be a false positive, and then a second test to confirm. And you use the RPR to look at disease activity. Did it go up? Did it go down? If it went up, they have new infection or an active infection. If it went down or is serofast, a low number, that means they've been treated and they're okay. So if I can get one teaching point home to you, it's just what's the treponemal and non-treponemal test, and thinking about, I get one test, now I have to confirm it. And you should be able to analyze tests no matter what order they're thrown at you. And I'll stop there and ask for questions, because it is confusing. But my goal is to give you the confidence to take it and look at it and go, I have the gestalt. This is what it should look like. And if I did it so well, none of you have questions, we're going to record this and I'm just going to make a little tape. All right, I think we can go on.
All right. Okay, and we can always come back to if you guys have questions going forward. So then also included here our UW test. I'll turn that over to Dr. Sabo as well.
Yeah, so again, this is reflecting what's on the other screen. So when you guys order a test, what you're going to get back first is this, the IgG, IgM antibody bioplex. This is the treponemal specific test. What it actually does is there's little beads that have the not the S antigen, sorry, I've been doing too much COVID. They have one of the syphilis antigens on it, and it finds antibodies that just bind to syphilis. And that'll come back positive or negative. If it's negative, the testing stops. If it's positive, then the RPR is sent out. And you'll get first you'll get a positive or negative result, and then you'll get a quantitative result. And then if that's positive, you're done. If it's negative, they'll send the TPPA, which is another one of the specific treponemal tests. And I always get this one wrong. I think this one's ELISA-based, but they'll send one of those tests to confirm. But it's a lot of little letters and test results that come back. You really want to look at what's their initial IgG, what's their RPR and their RPR quant, and then what's their TPPA to interpret.
Great. And then again, we talk about the specificity, and we said that the non-treponemal tests are not as specific. So things I think you guys probably are aware of. False positives for RPR can happen in pregnancy, lupus, autoimmune disease. False negatives in very early syphilis. And then false positives of the treponemal test are probably going to mean that you've some other kind of spirochete infection, such as malaria or leprosy. So they're much likely to be false positive for other reasons. And then the second part of this question is, why are we testing this woman's CSF? And I think you guys have a good idea. So we're concerned for neurosyphilis. So she has no other signs of infection other than altered mental status. So it's likely that she had latent syphilis. So we can divide that into two types. Early latent syphilis, which is going to mean either in the first 12 months or there's clear signs of primary or secondary syphilis. You have to be able to mark that it was definitively in the first 12 months. And then anything that doesn't fall into that category is going to be latent syphilis. So either not primary or secondary, or we just cannot prove that it was in the first 12 months. And that's important because it's going to change how you treat syphilis. And then any point along this line, you develop neurosyphilis, and that again will change how we treat the patient. So with that said, treatment for syphilis for primary, secondary, or early latent is going to be IM penicillin and just a single dose. Late latent syphilis, or we just don't know how long the patient had it, or we know that it's tertiary, is going to be IM syphilis, 3 doses once a week. And then lastly, this is why we need to test the CSF. We're going to treat neurosyphilis with IV penicillin. And then, so because it changes treatment, we know that we need to confirm whether the patient has neurosyphilis before we start treatment. And then to do so, we're going to do an LP, test the CSF for protein, glucose, cell count, and then ultimately VDRL testing. And if that's positive, we'll know we need to do IV. I think that's the end for this question, so I'll open that up to questions from the group. With neurosyphilis, would you typically see that low serum RPR?
You can see any RPR. And you can get neurosyphilis at any time. It can be early. It can be right after infection when they have the chancre. And at that point, you would have a low RPR. It can be very late, at which point their RPR would have gone up. And then after many, many years, probably kind of come down and started to fizzle out. So it doesn't matter. Would you ever treat for presumptive neurosyphilis without testing the CSF? Good question. That's actually a little controversial within the STD group here. I typically like to get the CSF because what you're looking for, you're mainly looking for cell count. Even if the VDRL is negative, the cell count is above 5 in HIV patients and above 10 in non-HIV patients, you would still treat because that's not normal. And so you want to follow it and make sure it goes down. I think you would make every attempt you could to get the lumbar puncture, but if you had a patient where you absolutely couldn't and you had a suspicion, you would probably just treat. And then if someone is serology demonstrating latent syphilis, but no obvious neurosymptoms. So this, yes, that's a good point. Yeah, you'd only do it if you had obvious neurosymptoms. And so this lady, it was the altered mental status, other neurosymptoms, ocular syphilis, so they can have a uveitis, they get scotomas and pain, they can have tinnitus and muffled hearing. That'll all buy you an LP. Did I answer your question? And then what counts as neurosymptoms? Occasional headache, no, but they'll report like a new kind of like, yeah, I've got a headache all the time. I've also seen loss of balance. So I have a pretty low threshold for sending someone for an LP at this point. And if you see a patient where you're worried, you should do a good neurosymptom screen because it's amazing what comes up. Nobody tells you about their muffled hearing, and then you talk to them and they're like, oh yeah, I've been hearing like I can't hear. It's like I'm underwater.
All right, do we have any other questions? All right, looks like that's it. So I think we have time for one more mix-up question. All right, so question 3. A 33-year-old man is seen to establish ongoing care. He underwent kidney transplantation 3 years ago and has been stable since then with no episodes of rejection or infection. A review of his immunizations indicate he received his scheduled childhood vaccinations and his pre-transplantation immunizations, including Hep A and B, and the pneumococcal conjugate and polysaccharide vaccines. He's never received the varicella vaccine, and he was last administered a diphtheria tetanus immunization following an accidental laceration 8 months ago. Medical history is significant for post-infectious glomerulonephritis as a child, resulting in end-stage kidney disease requiring transplantation. Medications are cyclosporin, prednisone, and mycophenolate mofetil. On physical exam, vital signs are normal. A well-healed abdominal incision is noted, but the examination is otherwise unremarkable. Which of the following immunizations should be given now? A, the 13-valent pneumococcal conjugate vaccine. B, the 23-valent pneumococcal polysaccharide vaccine. C, tetanus, diphtheria, acellular pertussis, so your Tdap vaccine, or the varicella vaccine, or D.
There's a request to show the question stem again.
Oh, sure. See if I can, oh. Ignore that, guys. Didn't see the answer. Which part of the stem do we want to see? That's kind of the most important part of it, so I'll leave that up.
I'll give another 10, 15 seconds. We have like 40% of people voting right now.
Put the answer you were thinking before
Accidentally.
Because that'll help me explain, pick up on where there's difficulty. That said, I thought Nicsat made a pretty poor question here. I figured out what they were going for, but it was a little opaque.
All right, so we have, majority of people are picking the Tdap, and that is correct. We had a little answer reveal here by accident, but hopefully that's what you guys were planning to put, but we'll walk through that. All right. All right, so I'm gonna walk through this, this recommendation slide from the CDC on vaccinations for immunocompromised patients. So this is up on their website, and this is for any immunocompromised patient excluding HIV, so that'll include our solid organ transplant patient. So first here we have our inactivated flu and recombinant flu, and that they should, as any other patient, receive 1 dose annually. This is going to be our live attenuated flu, which is not recommended because it's a live vaccine. These patients are immunocompromised. For our Tdap or tetanus diphtheria, just like any other patient, as a child, they're going to receive the Tdap, and then as an adult, at least once they should receive the Tdap, followed by just the TD, or it can be the Tdap every 10 years as a booster shot. Our MMR and varicella vaccine are not recommended in immunocompromised patients because they're live vaccines. And then here we have, this is our Shingrix and Zostavax, and Zostavax is live, so again, not recommended. HPV is recommended in the normal sequence. And then we have our pneumococcal vaccines, and these are recommended, but the patient will receive doses of these before getting transplanted. And then hepatitis A, B, and our meningococcal vaccines are all indicated if the patient is otherwise at risk. And then lastly, we have the Haemophilus influenza vaccine, which is mostly given to patients with stem cell transplants. And I'll turn this over to Dr. Sabo if you have anything to add to these guidelines.
Yeah, absolutely. So the couple comments I have is the reason for the one-time booster of Tdap in all adults is because we now give it, the AP is acellular pertussis. We used to give just killed pertussis, but the problem with that vaccine is that some small but significant percentage of babies, when they got this, would scream like a banshee for 24 to 48 hours. It was a really strange side effect, but as you can imagine, parents really didn't like it. And so they switched to an acellular version. So it's not the whole killed bacteria. It's one where it's not the cell wall. There's just other antigens. and it's not as immunogenic. The immunity doesn't last as long. So I actually give my HIV patients every year, every 10 years when they get their TD, I just give them a Tdap to boost that up. But the right answer is at least once for every adult, they should get the Tdap. I think this is in terms of the zoster vaccines, just remembering that the Shingrix is protein-based, the one that we prefer to give now because it's more immunogenic. So at age 50, any of your immunocompromised patients can get that. And then for this question, the part about it that I really didn't like is the pneumococcal vaccines. I think the rationale for it was, well, since you know they got it right before transplant, and that was 3 years ago, you know they won't need a booster of their Pneumovax for 5 years. And I was like, well, that's kind of weak. What if they got their pneumococcal vaccines 2 years before their transplant? Like, you don't know that it was at 3 years and then they got transplanted. But I think the point is that if someone's at risk, they get the Prevnar, the PCV13, which is your Hapten carrier conjugated protein-based pneumococcal vaccine. Then anywhere between 8 weeks and a year later, they can get the PSV23, the Pneumovax. They get a booster of that Pneumovax at 5 years, and then they don't get another booster till they're 65 years old. And it is confusing. If you ever have any questions, I would go to the CDC website. They have algorithms and tables for all the confusing ways that you can mess up the pneumococcal vaccines because the guidelines keep changing. And I saw Sarah wrote, why does it say Shingrix is not applicable? I'm not sure why they're saying that's not applicable. I can't remember what their reasoning is. I mean, I think it's just because everybody over 50 gets it. Yes, and Shingrix is still over age 50 if you're immunocompromised. So you give them the Shingrix at age 50 like everybody else. And we do try to give, I'm thinking now to my SOT time. Sometimes but this was with the live vaccine. Sometimes pre-transplant we'll try to immunize them. I'm not sure how they've changed this since I've been off, so I won't go too far into that. But age 50, it's safe, it works.
Great. Let's move on to the next slide. And again, I think Dr. Sabo went through that pretty well, we're feeling that they probably already got their pneumococcal vaccine. And again, the main takeaway here is we're not going to give immunocompromised patients any live vaccines. And then I guess, do you think we're out of time or do we have time for one more?
We've got two minutes left. So depending on how short the question is, but probably wouldn't have a lot of time for discussion afterwards.
Okay, maybe we'll actually, at the very end, I have some rashes. Maybe we'll just go through them real quick. I borrowed them from Steve Disharoom. So we'll just quickly go through these. These are some pictures from MixApp. So we have this patient that had a recent tick exposure, presents with meningismus and photophobia, thrombocytopenia. They're febrile and tachycardic. Their CSF studies show lymphocytic predominance, and then they're negative for Rocky Mountain spotted fever serology. They have rash on the trunk, extremities, palms, and soles. And we didn't set up a poll for this, but if anyone wants just to type into the chat what you guys think this is, I'll give you a couple seconds. All right, we might not have any takers, but I also don't want to, oh, ehrlichiosis. All right, only had one guess. So actually this is Rocky, Rickettsia, we got a couple more. This is actually Rocky Mountain spotted fever. So positive serology may not actually be present in the first 14 days of the symptoms. And then you're going to treat with doxycycline.
This is a classic boards question. The reticular lacy rash on the hands is I was like, well, this is Rocky Mountain spotted fever. And then I had to take a moment and think about it. I'm like, oh, they're trying to get at the fact that you could have a false negative early on in infection. That was what the question's getting at. But that's what it is. Ehrlichia less rash, and then Lyme, you get your bullseye rash. But there aren't too many that give you a rash like that.
All right, great. Well, I think that's probably all we have time for. Thank you guys for coming in. Dr. Sabo, thanks so much for giving us some of your ID wisdom on these questions.
Thanks, guys. Thanks for letting me join you. This was fun.
Thank you both so much. I certainly learned a lot myself, and I think everyone else probably did too. For the group, we'll take a 10-minute break and come back at 9:55 for Izzy Westling's talk. Thanks, everyone. Izzy, if you want to practice, I was going to say, if you were wanting to practice sharing your slides, you're welcome to.
I'm here. I have to pee, and then I'll come.
You can take a break.
Yeah, I'll
TMI.
It's okay, John. I don't care if the whole residency class hears that I am also a human being who drank too much coffee.